Assalamu alaikum. Okay, so first I should introduce myself. So I can see that some people have joined from Bangladesh and only. So my name is Dr. Badurman Khizr. I am I had the Global Emergency Medicine Program, which is conducted by the Dr. Ishfaq Ahmed Swatia. It's a 2-year program. And I'm also faculty member of London Global Emergency Medicine Program. I have worked as assistant director in teaching hospital and worked as a senior medical officer in ICU at the hospital. Or I have done my MBBS, full MRCEM, MPhil Public Health. So that's my short introduction. And we have already running the MRCEM primary course at the PrepXperts Online Academy. And we have started the MRCEM intermediate course, which we will start from 10th April, regular classes. And we have some enrollments before that. And for that, we are going to conduct these 2 sessions as a free session for all as introductory session. In this session, I will discuss different topics and MCQs so that you can get the idea that how will we run our course. And the other thing important that you must know that how the MCQs are asked, how the questions are asked in the exam. That's very important. The other thing I want to clarify that there is no one who can pass you. It's you who have to pass. Either it is best teacher in the world who will not pass you. It's you who have to pass. Okay, that's very important point. Every teacher is best. I will not. I will say that I am best teacher. Anyone else will say that I am best teacher. I will run the best course. Everyone is best. Everyone is running a good course. But the most important thing is that you have to grab the knowledge where teacher is giving you. How are you taking these sessions? How are you implementing this knowledge in your real life? How are you choosing the MCQs? That's what you have been told. Are you doing the smart study? Are you doing only hard work, not smart study? So that's very important. I have conducted a detailed session on how to prepare the SBA. That's very important. You can see if anyone here who have already attempted the SBA. Anyone here? I know Ahmed. He has attempted. Anyone?
Sir, I
Yeah.
took one attempt in last September.
Your name? What's your name and you are from?
Mo, Dr. Mo.
Okay. Oh, good. How many marks you got?
I had 116.
Oh, that's hard luck. Okay. Uh, so, anyone who have attempted the exam, and I have already conducted the session. If you have already attempted, you know there are about 300, 400 topics that are repeated every time. They will give you question from these topics. Okay. And about half of the question will come from those topics. That means paper is out. About of all these conditions, most of the people fail because they don't understand how the question is being asked and how to grab, how to look over the part of the topic, how it is being asked, how to study it, how to extract the knowledge. That's very important. And don't worry, Dr. Mu, you will pass, inshallah, next time. Best of luck. And
Inshallah.
I want to mention, I have already mentioned that uh, who fail with the margin, they are at more risk to fail next time. If they feel that they will pass next time easily, you have to work hard more. That's very important. I have already told in my last SBA session, I conducted for the SBA preparation webinar. I mentioned that who have got more than 110 marks in the last 10 because passing was 117, and they are at they all are at risk to fail again, because most of the time, because we fail with margin, we think that we will pass next time easily. We take things lightly. When we go for next attempt, we fail again. I have seen many my colleagues, my juniors, my students to fail again. So that's the reason. So you have to work hard, smartly work hard. That's the important. And you have to understand the question, how the question is being asked, how do you answer it? Dr. Mu, did you get any course last time? Either you did the self-study.
Sir, I went through MRCEM expert and I got some hand notes.
Okay, that's good. So any resource, anything that is important. Okay, that's but I have
And I was lacking in SLO 7. My others were all are good marks, but my SLO 7 was not very poor.
okay, I got it. But the most important thing I have already mentioned that SLO7 is very tough things. There are many difficult things. You you can't get marks, maximum marks in these, but there are some easy things you can get maximum marks. So you have not to lose marks in this session. Today I will discuss about three parts, uh, some topics of three parts: trauma, recitation, and procedure skill. And tomorrow I will discuss about SLO1, SLO5, and the SLO7. So that's how we will have these introductory session. You can assess that out. Okay, so we start. So this is the question. So what you see when you will get this question, you will read this question. Okay. 24-year-old male presented to the ED with the right shoulder pain. His arm is internally rotated and adducted. X-ray is given. 25. Okay. So when you will go for the X-ray, so you will be happy. You are all happy because you know the diagnosis. What's the diagnosis? Please mute. Okay. Please keep your mic mute. What's the diagnosis?
Posterior dislocation?
Yeah, everyone knows. Everyone knows it. Everyone is happy that answer is posterior. When you will go for the answer, there will be no posterior dislocation answer. That will happen in your SB exam. If if anyone have attempted, like Dr. Moser, Dr. Ahmed, I know him, he has attempted. So you know that when you will see the option, and Dr. Taiba has also attempted. So there will be no option like this, that posterior. So they will ask, what is correct answer in it? He is unable to touch the contralateral shoulder. He is unable to internally rotate the arm. He is unable to adduct the arm. We need urgently refer the patient to the ortho department. He is unable to externally rotate the arm. So these type of questions they will ask. Okay, that's the main thing I wanted to tell you. So now we will go to another presentation. I will teach you about upper or injuries. Okay. So there are three types of glenohumeral joint dislocation and anterior shoulder dislocation. That is interior shoulder dislocation. Okay. That can be posterior shoulder dislocation, and the other that can be inferior dislocation. Okay. So the most important thing important is that whenever you are doing the intermediate or whenever you are doing the MRCOG, always remember that you have to act like the patient is in front of you and you have to take the decision. That's very important. I also told about the things that what is meaning by the initial management, what is meaning by the immediate management, what is meaning by the definitive management, what is your next step, what are these meaning. I have already told in my SBA webinar. So these are very important. Anterior shoulder dislocation, the most common is that will be done by forceful abduction, extension. That is the clinical features for the anterior shoulder is arm abducted and externally rotated. Okay. Whenever the patient will come to you, the arm will be abducted and that will be externally rotated. And the other thing that will be inability to touch the contralateral shoulder. Patient will be unable to touch the contralateral shoulder because arm is abducted and externally rotated. He can't adduct the arm. He can't do the internal rotation. That's why he can't touch the contralateral shoulder. These are anterior shoulder dislocation feature. This question has been asked in the exam. Okay. So investigation, first, what will you do? You will do the X-ray. Okay. X-ray to see there's any dislocation, and the other is the reduction techniques, modified Cochrane's method, Stimson method, Cunningham technique. These are also important for the OSCE and for the intermediate. Modified Cochrane's method, how you do? First, we will learn that in the modified Cochrane's method. First, you will ask the patient to, you can see me. You ask the patient, you will do the adduction, okay? Then the external rotation, that's the method. Then you will do the flexion, and that's the modified Cochrane method. But the most important thing it is, you are not doing any traction on it. You are not doing applying the force. Cunningham method, it is the massage of deltoid, trapezius, tricep brachii. So these three muscles you must remember that what are you doing in the Cunningham technique, which muscles, the massage of which muscle you are doing. That's very important. So reduction technique. So in the management, you can see that first you will do give the any patient which is coming to the emergency department. The most important thing, you have to make the patient pain free. You will ask, do you have any pain? Okay. If patient is coming with a difficulty with it, you have to make the patient comfortable. That's very important. If patient is coming with the pain, you have to make the patient, that is immediate management is pain management. Then is the reduction techniques, anything else is come afterward. So that's important. Immediately you have to make the patient pain free. Then for reduction, what will you do? You will do the procedural sedation before the reduction, and you will check the pulses in the examination, sensation, if there is any sensation loss, any absent of pulses, any neurovascular molecular, then you have to refer urgently. Then you have to be vigilant. Then you have to refer the patient on urgent basis. That's very important. Okay, that is Stimpson's technique, that you have to hanging over the down, that is traction technique, then the modified Mills method, Cunningham technique, massage. Anterior shoulder dislocation, that complication that can be injury to the axillary nerve. So they will not give you, either it is a primary, it is an intermediate, they will not give you the axillary nerve injury. They will give you this diagram, okay? And you know that it is anterior shoulder dislocation. You will diagnose it because you have learned it. But they will give they will give the big scenario and they will say, you are doing the examination of this patient and what will you find on the examination? You have to see the X-ray, you have to diagnose it's the anterior shoulder dislocation, and then you have to tell that what complication what you will find on the examination. They will give you that you will find the loss of sensation on the lower part of deltoid. That means that is supplied by the sensation supplied by axial nerve. They will give you the patient can't do the adduction. Abduction, that's the other clinical feature. Patient can unable to control it. So that's how they will give you. Either they will give the trees axial nerve, and it is also explained the trees manner. They will give the function of trees manner. So you have to think broader way. So that's the main purpose of intermediate and OSCE. That's the both. Intermediate is more tough as compared to primary and OSCE. It's very difficult. That's why, because they are assessing your knowledge at very difficulty level. So that's very important. So posterior shoulder dislocation, clinical features, that patient is unable to externally rotate and abduct the affected arm. Okay, patient that is opposite to the anterior shoulder dislocation, patient arm was already externally rotated and already abducted. But in this, patient is unable to externally rotate and unable to abduct the arm. So that's the light bulb SAM you have seen in the diagram. I gave you the MCQ. Other important thing in the anterior shoulder dislocation, these are heel sac lesion and Bankard. So heel from the heel area of the head of humerus. That is head of humerus is the heel area. So that means any compression fracture on the heel area, mean head of the humerus, that will be heel sac lesion. You can see, and Bankard mean the bank of the gynaecology, that evulsion of that is called Bankard lesion. So that is posterior shoulder dislocation. Other is the inferior dislocation. You can see in this that is occurring due to the hyperabduction force which levers the neck of the humerus against the acromion. So what will the clinic patient arm would be held abducted above the head. That's very important. And elbow is flexed. Elbow will be flexed and arm will be abducted. So this is also very important. These clinical features are very important. So other topic. It is asked. So now after that I will go to so that is isolated ulnar fracture or nightstick fracture. Why it is nightstick fracture? Because whenever you are going to be, anyone is hitting you with the stick, you are going to be defensive like this. So whenever you are defensive, if you can see me, yeah. So defensive, so any time you will do defense like this. So stick will hit here. So that will be the fracture of the distal part of the ulna. So that is isolated ulnar fracture. Either it is called nightstick fracture. So how will you manage it? You, if it is undisplaced, any displaced fracture, you have to refer. Okay. Any neurovascular blockage involvement and neurovascular involvement, any displaced fracture, any comminuted fracture, any complicated fracture, you have to refer because you are an emergency. You have to deal with only stable patient. Mean stable like fractures that don't need urgent intervention, that you have to do apply the POP. You can ask him to come into the OPD. So in the management, you have apply the POP flexed at the 90 degree. That's also very important. They can ask. So other thing, if it is angulated or displaced, then you will refer. Other is important is because I am teaching for 1 hour few topics from trauma, and then I will teach 1 to 2 topics from resuscitation. After this, we will do the MCQs and I will assess that you have got the knowledge which I have given you or not. Montegia fracture dislocation, fracture of the proximal third of the ulna with a radial head dislocation, that is Montegia Manchester United. You can remember from the Manchester United, Montegia. But that's important that it is proximal third of the ulna. You can see here, it is proximal third. If it is distal ulna fracture, that was nightstick. But in this, it is proximal third of the, and also the radial head dislocation, that is Montegia fracture Manchester United. Okay. So the other is the Gleazy fracture, that is GR. You can remember from the this one. So that is GR. You can remember from GR, that is distal third of the radial shaft. That is distal third of the radial shaft, accompanied by the dislocation of the distal radioulnar joint. So that is GR. So that's how you can remember. Other important thing, how will you manage it? That's also very important. So in the Montegia fracture, because it is dislocated, okay, so that's why what you will do in the emergency department, you have to only make the patient pain free, okay, rise, elevation, okay, and compression, and then you have to refer for the open reduction internal flexion of the ulnar fracture. So you have to refer. Your work is to refer the patient to the orthopedic department after making the patient pain free, stabilizing the arm, making it comfortable. Then you have to refer it. Afterward, they will admit and whatever you do. That's very important. Okay, in Gleazy fracture, so in this you have to also urgent orthopedic refer because there is displacement. Okay, whenever there is displacement, dislocation, you have to refer it. But what you have to do in the emergency department before referring, that is immediate management. You have to make the patient pain free, immobilize, apply the POP. Then after that, you have to refer or the consultation. Any question so far? So now you solve this question. What is the answer of it?
E. E is the answer.
Okay, give your answer in the chat box.
All right.
Okay, now I have, you got the topic and you are able to answer it. Is that so? Is there any confusion in these two topics we discussed?
So, travel को book.
Okay, next question. No, who will read the question? Although I have highlighted. Who will read the question?
Okay, I can read this. A 33-year-old woman attended the emergency department with palpitation, feeling breathlessness. She had felt fine until around 3 hours ago. When these symptoms started, she feels lethargic and became dizzy on standing. She has no significant past medical history and is not allergic to any medication. Her vital signs are as follows. The SpO2 is 96% on room air. Respiratory rate is 20 breaths per minute. Heart rate is 220. BP 108 by 65 mercury. Temperature is 36.5 degree Celsius, and her initial ECGs are shown below.
Okay, so what you can see on the ECG, everyone can answer in the chat bar. And what you can see,
We've
VT, okay? Ventricular tachycardia. It is narrow complex, a broad complex VT. Okay, so everyone have read the algorithm? Who have read the algorithm, they can say yes. Recess console algorithm. Yeah, monophasic, good. Dr. Okay, so everyone have read the algorithm? Okay, so no, what will be the answer? Okay, if you have not read it, if anyone have attempted like Dr. Mu, Dr. Taiba, you have read it, I think you can answer it. It's good to read all algorithm. Okay, we will teach you, but you must know it because if you are working in emergency department, any setting, you must know them. These are life-saving. Question, who will read the question?
Sir, it will be B.
Okay, read the question and then tell why it's B. Read it loudly, Doctor. No? Either who are reading, who can read it again. Question. What would be the course of management? It's a shockable rhythm. Patient given 3 shocks. If not revived, then will be given injection adenosine. It's shockable rhythm. Patient given 3 shocks. If not revived, then will be given injection amiodarone 300 mg in 10 minutes. It's non-shockable rhythm. Patient has been given injection amiodarone 300 mg. Then after that, no revival. Injection 900 mg will be repeated for 24 hours. It's non-shockable rhythm. Patient has been given injection amiodarone 300 mg. If not settled, then after that, 3 shocks will. It's SVT. Patient may be given adenosine. I make this question on my own. So First, how will you know that this is shockable or non-shockable rhythm?
If patient vitals are stable, then it is non-shockable.
There is heart rate.
Okay, if patient vitals are stable, so that means it's
VT with pulse.
if patient vitals are stable, that means it's, you say that it's non-shockable. That's what you were telling? You were telling it?
It will be shockable if it's a pulseless ventricular tachycardia. But this patient has got a pulse. So it makes it not shockable rhythm.
Okay. So, okay, now first I will tell you the algorithm. I will teach you, then you will solve it. Okay, that's good. Okay. Okay, this one algorithm. I think you have, if you have read. Voice is clear? Someone is saying their voice is not clear. Voice is clear?
Yes, it's clear.
Okay, so I will teach you that about the adult tachycardia algorithm. Then we will again solve this question. Okay. So adult tachycardia, first, whenever the patient has approached to any patient that have come with a tachycardia, first you have to do the ABCD approach. Okay, that's very important in any resuscitation station, any resuscitation MCP, any resuscitation OSCE station. Check if oxygen patient saturation is more than, obtain IV airways maintained, and everything. Okay, airway, breathing, airway is painted, then you will go for the breathing. You will see the breathing, saturation, respiratory rate, trachea, everything. Then you will go for the C, and you will get the IV access, blood pressure, heart rate, capillary fill time, pulses. You will do the 12-lead ECG. Okay, and then you will get the sample DE. That's the ABCD approach. That you will get the sample. If there is any reverse, you have to treat it. But if patient has come with any life-threatening features, this is very not vitally stable or unstable. That's not important. Okay. If patient saturation is 88%, that is vitally stable or unstable?
Stable.
Unstable.
88 is unstable. According to the vitals. According to the vitals is unstable. Then you will give the shock? No. You will look only these life-threatening features. If any one of these life-threatening features are present, that is shockable rhythm. Okay. If any one of these life-threatening features is not present, that means it is not shocking. You got it?
Yes, sir.
Okay. Life-threatening features, shock. Please mute. Okay, shock mean the blood pressure, patient is in a shock, mean blood pressure is less than 90/60. Okay, patient is in a shock. Syncope means patient has a loss of short interval of loss of consciousness. Okay, loss of consciousness. Myocardial ischemia, if patient is having complaining of very severe chest pain with the tachycardia, you must consider as life-threatening feature. Okay. Ischemic, either you have found any changes on the ECG. that is myocardial ischemia. Patient has any chronic history, cardiac heart failure history, severe heart failure history, that will be mentioned in the history. Okay, so these are life-threatening features. Okay, so that's how will you remember it? Patient has come to you, patient has complaining of chest pain. Patient told you that he has a loss of consciousness for a short interval. He has a history of heart failure. Now you check the blood pressure. Patient is in shock. So these are 4 things you must remember: shock, syncope, myocardial infarction, severe heart. Syncope, most of the people mix it with the dizziness. Dizziness is different. Syncope is different. Okay. And dizziness, you don't lose the consciousness. You're conscious, but you are feeling dizzy. In syncope, you lose the consciousness. That's very important. If these features are present, then you will consider it shockable rhythm. Either it is VT, SVT, doesn't matter. You will go for the synchronized shock. Okay? That is synchronized shock. Pulseless VT is different thing. Then you will go for the asynchronized. Synchronized shock. Okay? You will go up to 3 shocks. You will start from 120, 150. You can for VT, you can start from 150 we can start from 120 and increase the dose. And before that, before sedation, any shock, you have to sedate the patient. That's also very important. They can ask, either they can give the question and you know that it's a shockable to them, you have to give the shock, and abruptly you go the option and choose the shock. But there was the option that you have to sedate the patient. What you have to do, the immediate management for this, there is that you have to give the shock, you have to give the sedation, you have to give the amidron, you will choose the shock, but immediate is give the sedation, then the shock. Okay, either sedation and shock, that's very important. Sedation anesthesia if conscious patient. If patient is conscious, then you have to sedate, immediately sedate, then give the shock. If it is unconscious, then you directly go for the shock. If 3 attempts of shock, after that, rhythm is same, there's no decrease in heart rate, patient is adult, patient in tachycardia, then you have to give the amidron 300 mg in 10 minutes. And after 10 minutes, if no survival, then you will repeat the shock. Shock, re-shock, amidron, 10, 300 mg, 10 minutes. Then shock. That's for the unstable. And you can ask for, after that, you can ask for the help for the cardiology team. Always ask the help. When you are going for the shock, you have found this patient, you can ask for, you can call the cardiology team. They will come for the help. That's all. If these 4 features are not present, that means it's a non-shockable rhythm. Okay. So you will see that it is the regular, irregular. Okay. It is regular or irregular. If it is regular or irregular, you will see first the narrow complex and broad complex, then the regular, irregular. So for the narrow complex, that means QRS is less than 0.12 seconds. For broad, it is more than 0.12 seconds. Then you will see it is regular, irregular. If it is regular, narrow complex, first you have to do the vagal maneuver. It can be carotid massage, it can be modified Mussalva maneuver that we use in recent guideline, modified Valsalva maneuver. We use it with syringe, and that you have to do uplift the legs, and that's how we use it. That's very effective. I will use it. And if vagal maneuver ineffective, first line is vagal maneuver, then you will go for the medical treatment. You will 12 mg, 18 mg. Everyone knows it. But what you have to do, you have to, in this, you have to check the contraindication. If patient is down case of asthma, COPD, anything, any drug that is he taking that can decrease. If it's any drug is given the history, that is decreasing its dose, you have to increase the dose. That is increasing its effect, you have to decrease the dose. That's very important. If you have given the maximum, if ineffective, then you will go for the verapamil and beta blocker. If medical treatment is ineffective, and you have done all the intervention of medical treatment, when you will repeat the adenosine? Anyone can tell? When you will repeat the adenosine?
No.
After how many minutes? You have given the 6 mg IV bolus. When you will repeat it?
Immediately.
Doctor,
We will give adenosine in 2 to 3 seconds interval up to 36 milligram. Then
no, up to in 2 to 3. We have to give it slowly if there is no central. Ideally, we give in the central line, but if not available, then we can give it in the. I am asking when you will repeat the second. If you have given the 6 mg, you are not going for the 12 mg. You will give it after 10 minutes, 5 minutes, 15 minutes. When you will repeat it. That's also very important. Anyone who have given the, because who have not attempted, but they have not read it. Dr. Muzna, Dr. I know, Dr. Suhail Bhai, Dr. Taiba, when you have to repeat it. Okay. No one could not give the exact answer. Always remember after 2 minutes. Repeat it after 2 minutes. Repeat it after 2 minutes. 2 minutes. Just remember 2 minutes, no 2 to 4 minutes. Okay. So you have to repeat 6 mg. Then after the medical treatment, then you have to give the synchronized DC shock up to 3 attempts. If conscious, you have to do. Okay. Yeah, 2 minutes after first, second, third, after 2 minutes, you have to treat it. If it is irregular, then you have to treat as atrial fibrillation. We will learn about atrial fibrillation a little bit. If it is broad complex, if it is regular or irregular, okay. If it is irregular, you have to treat atrial fibrillation, and you will see that it's polymorphic, Vanderbrand. But regular, if it is VT, then it is non-shockable. So you have to give the amidrone 300 mg in 10 minutes. Remember, in 10 minutes, okay? So 300 mg medical treatment have failed. Then what you will do? You will, if it is ineffective, you will go for the synchronized DC shock up to 3 minutes. That's very important. Okay? Medical treatment is failed, go for DC shock. DC shock failed, go for medical treatment. That's very important. Any question? Then we go for the MCQ. Any question? Okay, so now who will read? Who will read it and will tell according to algorithm what's the diagnosis, and then we'll tell the answer. Who will read it?
You can read it.
Well, okay, you can.
A 33-year-old woman attend the emergency department with palpitation, feeling breathless. She had felt fine until around 3 hours ago when these symptoms started. She feels lethargic and become dizzy on standing. She has no significant past medical history and is not allergic to any medication. Vital signs are as follows. Oxygen sets 96% on respiratory rate on air, respiratory rate 20 breaths per minute, heart rate 220 beats per minute, blood pressure 108 by 65, temperature 36.5 degrees Celsius. Initial ECG is shown below. On ECG, it looked like broad complex ventricular tachycardia.
So first, what you have to see in this scenario?
It is stable, like patient is feeling dizzy but no syncope, and the BP is
Yeah.
stable. She's not in shock.
Okay.
She's
Blood pressure is stable, no significant past medical history, no chest pain, so no life-threatening feature.
yes,
It is
it is
stability.
stable. Yes.
Oh, good. No, read the answer.
Now, what would be the course of management? A, it is a shockable rhythm. Patient given 3 shots. If not revived, then will be given injection adenosine. B, it is shockable rhythm. Patient given 3 shock. If not revived, then will be given injection amiodarone 300 mg in 10 minutes. It is non-shockable rhythm. Patient given injection amiodarone 300 mg. Then after that, no revival. Injection 900 milligram will be repeated for 24 hours. It's non-shockable rhythm. Patient has been given injection amiodarone 300 mg. If not settled, then after that 3 shocks will be given. And E, it is in its SVT patient may be given adenosine. So the correct option is D. It's a non-shockable rhythm. First, we will give amiodarone, and if it will not working and patient would not be revived, then
Ah,
given with the 3 shocks, DC synchronized
okay.
shock.
So now how will I solve it? It will become easy for me. So you can see that you have come to know that it's a non-shockable rhythm. So A, B, and you also know that it's VT. So A, B, E, plus we have
Yes,
these are not options. Okay. So we have to choose between C and D. So it's
yes.
non-shockable rhythm. So here it is correct. But after that, no revival, injection 900 mg will be given. Yes, we do it, but that should be done in an ICU when patient will be admitted. That's the main thing. But in emergency department, you have to do the quick action. So you have to do, and as per the algorithm, what you have to do, you have to give the 3 shots. Okay, so that's why answer is D.
Okay.
Any confusion? Any question? I think no, we don't have time. We will discuss tomorrow. Next time. Next, I will discuss the next topic. Okay, anyone have read the hypothermic cardiac arrest?
In hypothermia, we give the 3 shocks. Then we have to wait for the temperature 30 degree. Is it, sir?
It depends that what's the temperature, okay?
What's the temperature?
Okay, if patient has went into the cardiac arrest with hypothermia, that this case also came in my occupation, hypothermic cardiac. So you have to see when you will ask that patient is in hypothermia. When temperature is less than 35. Okay. So first you will see that what's the temperature. Okay. If temperature is less than 30, okay, less than 30, it is 28, 29, 26, whatever the temperature is, then don't give the adrenaline. There will be no effect of drug. No drug in hypothermia, temperature less than 30. Okay. But you can give the shock. If temperature is less than 30, you can give you can see that withhold adrenaline if the core temperature is less than 30. But you can give the shock if it is shockable rhythm. Okay. If it is shockable rhythm, you can give the shock. If it is non-shockable rhythm, you can't give the adrenaline if temperature is less than 30. If temperature is above 30 till 34, you can give the drug if it is non-shockable rhythm and cardiac arrest, but you have to increase the interval. You have not to increase the dose, you have to increase the interval. Either if you are giving in real life, I give after 4 minutes adrenaline, but that would be good to count. So you can remember 4 minutes. After that, you can give 8 minutes. You will increase it to 8 minutes. That is 3 to 5 minutes. They have increased it to 6 to 10 minutes when the temperature is 30 to 34. Okay, discuss another topic. This question has been asked many times. Okay. In the Mallampati score, first, if everything is visible, mean soft palate, uvula, fauces, pillars are visible, then it is class 1. Okay. And you can see that in the next class 2, if half of uvula is visible, then it is class 2. If only base is visible, uvula, then it is class 3. And if uvula is not visible, then it is class 4. That's how you can remember. These are procedure skill and procedures. This question has been asked if you are unable to can't intubate, can't oxygenate, that is in critical, then what you will do? You will call for help. So that you have to follow the scenarios, okay, algorithms. So what if they have asked what will you do next? You will call for him. Okay. You will declare the can't debate, can't associate. If they ask what will be your management, what your next management, then you will do front of neck or fauna. The mean you will do the cricothyroidectomy. It depends on scalpel, needle, on the base of age, on the base of scenario. That's different. Okay, you have to do the front of neck airway. So how they will ask the question. This question have come in the October types 2023. Can't debate, can't oxygen. And they also ask this question: emergency reject me patient if patient has come with the rejectomy. So what you have to do, first you will call for air expert, then look, listen, and feel. And after that, if patient is breathing and not breathing, then you will check the pulse and CPR, and then patient cardiac arrest. If breathing, first important is apply the high flow oxygen, okay, on the rejectomy stoma. Then next three things are important. Apply the high flow oxygen. Then you have to remove the stoma cover and inner tube. Okay. Then you will see that if you can pass the suction catheter. If yes, then it is patent. If not, then you have to deflate the cuff and look, listen, and feel. These three MCQs asked in three different ways. Then you have to remove the tube, and these first they will ask what you will do next. Okay, call for help, expert help, look, listen, and feel. Then what patient is breathing, they will give the scenario. What will you do? Apply the high flow oxygen. You have applied the high flow oxygen, and then what you have to do, you have to remove the patient. You will assess the patient, and then you have to remove the cover, then remove the inner tube. After that, you have to pass the suction catheter. So remove the inner tube after the apply the high flow oxygen. If you can't pass the suction catheter, then you have to deflate the cuff, look, listen, and feel. So then you will remove the tube from the rejectomy stoma. These algorithms are also very important in procedure skill. Only 8 to 10 procedures have been mentioned. These are very important. Wound management, airway, this comes in the tracheostomy, laryngectomy, airways, these are, and basic airway maneuvers, LMA, IGEL, these all come in the airway management. Wound management, that's very important. We will study from the RCM learning. Wound management, very given in a very detailed. Okay, digital nerve block, procedural sedation that come in the procedure scene, that's very important. So you can, if digit dislocated, that also have come in the exam. They have given the diagram of thumb, and they asked what will you do for procedural sedation. They were either the digital nerve block. So you can do the relocation and with the digital nerve block. So that's very important. Facial arc block. They have given this use. What will you use? 30 ml of them. They have given the weight. And they asked how much you will use the levovivacaine. 30 ml of 0.25%. If weight is 40 ml of this, that's they have given. Gastrin, intraosseous success. They have given this many times. You can see that proximal humerus is first choice if age is more than 6 years. If age is less than 6 years, then you can go for any one of that, but distal tibia we mostly use. Proximal tibia we mostly use below the tubal tuberosity. But if his age is more than 6 years, first choice always will be proximal humerus. Remember it. Don't go for proximal TB, anything else. And they will ask that how will you insert it, or where you will. They have asked it that insert just medial to midline to. These questions have been asked. They have given the confusing option. Medial tubular atrocity, they give the distal tubia, and they are which one is correct to give the pass the interosseous success. So they will confuse you in between. External pacing. That's very important. When you will give the external pacing, when you have given the injection atropine 500 microgram IV every 5 minutes, and you have given total of 300 mg. Okay, and at bradycardia algorithm, you are falling and patient is in bradycardia, life-threatening bradycardia, then you will consider the external pacing. You will go for the external pacing. There are non-invasive pacing, percussion, transcutaneous pacing, and invasive temporary transvenous pacing. But these are done by cardiologist. You don't do it. Okay, you do the external pacing if it is necessary. What's important in external pacing? Position of the pads. One pad you will apply on the right pectoral muscle just below the clavicle, and one pad on the left mid-axillary line. If it is not applicable, then you will apply the anterior posterior pads, one anterior pad on the left anterior chest wall, overlying the V2, V3 ECG electrode, and the posterior part between the lower part of the left scapula and the spine. So these are positions, because they also ask the question, they give the option that you have to change the position. So I will discuss it. So these are diagram, anterior pads and AP pads. Anteriorly you will place here, and posteriorly you will place here. That's how you apply the film pacing pad. So first, how will you, if pacing advice and adjustable energy, you will start from the lowest value, and then you will turn the pacemaker. You will shift the cardiac into the pacing mode. Okay, defibrillator into pacing mode. Then you will increase the current. Current is increased. The muscle of the chest wall will contract with each impulse, and the pacing spiral will appear on the ECG. You can see. So they will give you the question, and they will give you this diagram, exactly this diagram. They will ask what you will do. You have to increase the current. If you are starting from the 30, increase it until the pacing spice is followed immediately by a QRS complex. Until it is not followed by the QRS complex, you can see it is before T wave. Until it is not followed by the QRS complex, you have to increase the current. That's if it is followed by the QRS complex, that means electrical capture have been received. Then you have to look for the pulse for the mechanical capture. If the highest current is reached and electrical capture has not occurred, then you will try changing the electrode position. Continue to failure that electrical capture may indicate non-viable myocardium. That means you can see that if there any motion or any cardiac arrest, anything. That's a different thing. Palpable pulse confirm that mechanical response of the heart to pacing, pace QRS complex. That means successful pacing has been done. Okay, so today we have discussed one trauma case, one resuscitation case, and one procedure skill. Tomorrow we will discuss the SLO1, SLO5, one topic, 2 to 3 topics from each. So, and the MCQs. so that you can get the idea that how you have to study. Any question? Either we will end this session. If you have any query about the course, you can ask Dr. Vaji. I'm sending his number. Yes, yes. You are from LGM batch 25. Don't worry about it. Everything is taught in the LGM, X-ray and radiology. There will be radiological class as a doctor, Michael. Okay, so any questions so far? That was sample session, and tomorrow we will also have a second sample session about the SLO1, SLO5, and SLO7. And we will also upload it on Bluetooth channel. And you can see it. You can add friends. If anyone is worried about intermediate, they can join it. Any question you can ask? We are starting from 10 FL, and the LGM candidates were from batch 3, 4, 5. You don't need to join it. If any LGM candidate from batch 1, batch 2, they can join it after their session with the LGM. Thank you.